Over to you.
Can you hear us, Meera? And can you talk?
Yes, I can. Can you hear me okay?
We can hear you loud and clear. Thank you so much.
Wonderful. Thank you for that introduction, and it's great to see my Australian colleagues in the room there with you, and our colleagues also online. And it's been really great to be listening in to all the presentations thus far. So in typical Miriam style, she's given me an interesting topic to end the conference, and I think for the Australians it's to keep us awake, given it is quite late in the evening, and hopefully we can really stretch our thinking and our boundaries, and maybe raise some controversial issues for us to think about. And I think there's been a lot of presentations that have changed the lens in which we think about how we can improve our symptom control that we've heard already today. So the topic Miriam has given me is to think about multidisciplinary or interdisciplinary symptom control, and what it really means to walk the talk in terms of the philosophy that really underpins palliative care and drove the development of this area of practice across our disciplines, and the development of this as a specialty area of care. And to tackle that challenge, I would like to use the example of delirium, purely because it's something that I've been thinking about and doing research in for some time. And I think it really does give a good lens to think critically about this topic. And I'd like to acknowledge I'm talking to you from Camaragal land, which is the traditional land in northern Sydney, and as is our custom in Australia, to pay respects to those traditional owners and acknowledge them as the custodians of knowledge, and an important part of how we should think about improving healthcare and equity of healthcare going forward. So I wanted just first to remind ourselves of the WHO definition or description of palliative care. And the thing, I'm not going to go through the whole definition in detail, but I think the key things are that it has very much talked about early detection and really correct assessments. It very much focuses on thinking about issues well beyond physical symptoms, and that we need to work as a team, and it extends well into the care of the loved ones left in bereavement. And I'll come back to some of those principles and I suppose the challenge that this definition or approach poses as we think about optimising symptom control. And I think this quote really highlights how we do aspire to approach care, that we really are thinking about a whole of person, that when someone is unwell, that whole world is transformed, and this influences their sense of self and autonomy, their relationships with others, and their experience of the world around them. And I think time and space are particularly critical issues when you think about delirium, particularly, and the impacts of advanced disease on cognition. So one of the things that we're called upon to do is to take into account preferences, and a very early work, quite some time ago now, but I think possibly hasn't changed in the way we think about things in clinical practice, is that being mentally aware is ranked very highly by people facing a life-limiting illness. And that rank is not similar when you ask the physicians who are providing the same people's care. So there's definitely a mismatch in terms of how we're ranking mental awareness for this group of people. And this is just looking at that same data in a different way, that 92% of people attributed that as very important at the end of life compared to 65% of physicians. So you can see the gap is reasonably significant. And we also know that distress and suffering is high, and many people with delirium who recover recall the experience. And I think one of the critical things, if you look at these papers that were both done in advanced cancer, this seems to be despite people receiving antipsychotic treatment. So in the Barrera study from 2009, people were on haloperidol every 6 hours at 2 milligrams, up to 30 milligrams a day. And in the Breitbart paper from 2002, there were majority of people were on olanzapine, a number of people were on combination antipsychotics. So I think we have to think about how our prescribing, when it is driven to try and resolve distress and the recall of that distress, I think is a good flag to think about how successful we are. That the studies we have are really pointing to the possibility that the treatments that we're using from a pharmacological perspective may not be achieving that in many people. And then I think the other aspect that really in my research work, and as I've started to spend more time talking to people in the wards and who have had an experience of delirium, that there's really a breadth, just like any other symptom, that we, I think, really now think is really fundamental. That the experience of pain, for example, is very individual, and we don't go in with an assumption about what that pain experience might be for that person. We spend a lot of time exploring that. And I think we're probably a little bit behind in how we do that for people experiencing delirium. And this study from our Japanese colleagues really gives the range of experience and the meaning that families put on the experience of delirium at the end of life. And so this is one quote that really, from this family's perspective, that it wasn't necessarily a negative experience, that the person became more relaxed, that they seemed to be disconnected from the pain and suffering, and that there was an element of fun. But equally, a completely opposite experience, that the person had lost their soul, that they just stopped talking, and this is describing a much more distressing experience and meaning behind the symptom experience. And one of the things I think really is telling, and I think has been my experience when you start having conversations with patients about the choices and pathways in treatment, is that this partnership and is so critical. And if there is any ambivalence about decisions, that this is really a cause of distress and regret, and particularly when treatments may be perceived to add to cognitive impairment or be causing a sedation. And Imogen Featherston, her work, who you will all know, I think, really spoke to the need to relieve distress has been one of the key drivers in terms of how people are responding. And so these experiences really do drive what we do, but the depth in which we explore those is possibly the area where we can focus our attention as a team. So if we think about all of that context, and if we think about palliative care and the interdisciplinary work we do as being person-centred, and what are those outcomes we're aiming to achieve if we think about delirium as the example? So this was an interesting paper I found, completely unrelated to palliative care, but just thinking about what are the humanising dimensions of care. And I found it quite a useful construct in thinking about this, we're really wanting to help people who are experiencing the world through mood, feeling and emotions, be able to continue to connect with that, be active participants in care, be seen as an individual, not a diagnosis, that we need belonging and interpersonal connection during our clinical care, communication and information, that journey that they can retain their own history and that sort of longitudinal continuity as a person that makes us us, that is often so disconnected, especially in inpatient care, that a sense of place of a physical environment and trying to expand people's sense of personal identity. So when you think about how we might do this for delirium, I think some of the challenges are that we often think about delirium as a list of fragmented problems or risks, the risk of falling or the risk of harm to others, or the agitation or managing the hallucinations, rather than the person as a whole. We often struggle to enable and foster choice, though the paradigm of palliative care is really around preferences and values. We need to work harder to understand their background and context if they have a cognitive impairment, and may struggle to piece that together for us, and collateral history then becomes really important. We sometimes forget to foster and help family and loved ones connect with the person who's acutely confused, provide clear explanations about what delirium is and why it is happening, and think about how we can create that continuity where things are so unfamiliar, and focus on making the environment and the context in which we're providing this care more home-like, for example, and remembering to treat the acutely confused person with respect and dignity. So one of the first things I think is around precision. For pain, for example, we take a lot of focus in providing really a detailed description of pain, really aligned to a pathophysiological process as best we can, and it wouldn't be unusual for us to say that someone has neuropathic pain and the CT imaging shows X, Y, or Z, and therefore we're thinking that that is the etiological factor. But when it comes to delirium, we use very non-specific terms, terminal agitation, climbing out of bed, disorientation, and become very descriptive in the way we approach it. And really that has separated us from the evidence base around delirium care, and possibly led to downplaying its significance and severity. Now, one of the things we really need to do is really think about who has the greatest contact with the person, and in hospital environments that often may be the ward-based nurses, who often have the weakest voice in terms of a bit broader clinical team, or the staff who are working overnight, who in the daytime often have limited voice, apart from, I don't know, in the UK, if you have the ward book where the night nurses write messages to the daytime staff, in particularly the medical staff, in terms of their concerns that may have happened overnight. And I've often seen wherever it says confusion, that the junior doctor might just write no longer confused, because the person, of course, is perfectly fine during the day but has nocturnal symptoms, and this goes on for several nights in a row until a crisis occurs. and really thinking about the goals and wishes and how we achieve that understanding when someone is acutely delirious is a challenge. Congruent communication is really important. What delirium is, cause of delirium, the likely outcome, and the management plan. We have brochures and leaflets for many things and written information for many symptoms within our services, but many services don't have a comprehensive document or package of information around delirium. And I'd point you to the work that Shirley Bush in Canada has done, and her family information leaflet is available. If you do search for Berea continuing care, you'll be able to find that, which I find really helpful to be able to adapt to your local context. And the other reflection I've had is that it is an area where there often is conflict or differences in views amongst our interdisciplinary teams around the goals of particular therapies or the perceived impact. And these may be around why IV fluids are continuing, or why IV antibiotics or bisphosphonate is being used, and particularly between medical and nursing staff. I think it's important to really be quite proactive about describing the decision making, describing how the person themselves has been involved in that, and the net clinical benefit, but also the perception of the burdens from the perspective of the patient, because I think we layer our own perceptions about burdens onto these decisions very easily and jump to conclusions about what might be burdensome or not for a particular patient. And really, I think acknowledging the impact and stress that delirium care is hard work, and particularly for our nursing colleagues who are by the bedside. This is very impactful and stressful work. And I think often remember a nurse in one of our semi-structured interviews in work that I've done said, if you are 20 people on the ward and 18 are delirious, it's a really difficult thing to be able to provide this type of care for every single person in that ward. And the literature is really filled with examples of how poor delirium detection is, regardless of the healthcare system or population that you're looking at. And we know that systems are not in place to detect delirium early in palliative care services, and really reflecting back that early detection and impeccable assessment is really the underpinning of palliative care. And we will need to think about how we make sure, just like pain assessment is so core to the way we work, that cognitive and delirium assessment has an equal platform. So one of the things I think really has been an important learning for me is that we do jump to some assumptions about benefits and harms, and particularly when it comes to venipuncture imaging and IV cannulation, we put a lot more weight on the burden side of those things. But when you start thinking about including the person's views about how important is maintaining cognition for them, is treatment of the underlying cause, if maintaining cognition is a critical preference for that person, is that the best way to try and improve delirium symptoms, and how likely is the reversibility of that clinical event. Then the balance sometimes can shift if we have put the right things into both sides of the equation. And we really do need to make effort to include the person with delirium, that though delirium affects decision capacity, there are often many periods of time where it's actually very possible to discuss options of care directly with the person themselves. But it does mean coming back later in the afternoon or asking the ward staff to let you know when people are having a time where they're more lucid. And efforts to do that, I think, become really critical. So if we think about non-pharmacological interventions, thinking about this holistic approach and using the skills of all of our team members, outside palliative care, non-pharmacological interventions are established as really important in preventing delirium. And if you actually go and look at those studies, this is work led by Anne-Marie Hosey, really showed that a large number of studies are including people who very likely met the definition of having a life-limiting illness or an advanced chronic illness, or at least multimorbidity where the risk of dying was very high and frailty was also high. And 23% of the participants in these 29 studies had died within the 1 year of follow-up. So we don't know the adherence or outcomes in this group, but we do know that these people are being included in studies that underpin the evidence for this prevention strategy more broadly in our hospitals. And we recently completed a phase 2 study attempting to adapt these strategies for the palliative care unit context. And interestingly, we found that the highest adherence were to the exercise, the eating and drinking interventions and the reorientation, but we were less able to have good adherence to the enabling family aspect, which in itself we're focusing on the person and the people around them is so fundamental to the way we think about palliative care. There seems to be work to be done in this area. And these are elements which we used documentation as the evidence of adherence. Now, are these things that we do within fundamentals of care, but don't document them as critical? And do we actually need to place value on these as important parts of the clinical care we offer and be describing those in our medical records as comprehensively as we do, say, if we're titrating someone's opioid dose, we would probably write quite a comprehensive entry about why we've done that and the doses and the adjustments we've made. But possibly we're not writing as much about how we're having a discussion about what delirium is and the support we're providing to families to support the person with delirium, for example, as a comparison. And so when we think then about medicines, we are thinking about targeted symptoms, but need to balance that against unwarranted side effects. And we often think about medications alone. Are we actually adding non-pharmacological strategies into this balance? And are we thinking about those as reducing the target symptoms? Or are we thinking about these as not possible in the person that has inattention and apathy, for example, due to the delirium itself? And is our medication use potentially limiting our capacity or the person's capacity to engage in the non-pharmacological strategies as a bit of self-fulfilling sort of cycle? And so the interaction, I think, is quite complex and I think requires us to take a step back. And so in terms of the context, we need to start thinking about the mediators of distress, the concurrent issues that might exacerbate symptoms, realising that people are losing the person that family knew, and think about how the safety considerations influence the way we respond and react and maybe take a precedent. And so if we layer then in the evidence as it stands for non-pharmacological, for pharmacological evidence, when we start to answer questions, particularly around the clinical decisions we're trying to make in palliative care. If we ask the questions about behavioural, communication and perceptual problems, adding an antipsychotic doesn't seem to be improving those targeted symptoms compared to placebo. And if you think about asking the question that you've got an agitated person who is already on a reasonable dose of haloperidol, whether you add a benzodiazepine, then the outcome is that you will achieve sedation, and so people will become minimally responsive to verbal stimuli compared to if they remained on haloperidol alone. And what is it, if we think back to the first slide around what people are saying, is that they want those moments of mental awareness, and how do we then lay that evidence if that's what the person that we're standing by the bedside of is saying, how does that influence what we may or may not do in terms of our medication management? Are there other parts of our interdisciplinary team that are much better placed to work with that family, work with that person, listen to the story and the meaning that this experience is leading for them, and provide the information, support and context to work through that distress with them, completely independent of the use of a medicine. And so I think what walking the talk means to me in this concept is that we really need to start listening to the distress and of all the people involved in this scenario, and be really cautious of separating out the patient's distress to that of the family and staff. Start to really articulate clearly what it is we're aiming to treat, the rationale for your medication choice and the intent, and extend this even into our PRN, or even probably even more so into our PRN prescribing, which I think sometimes slips through the net. Start to consider if all aspects of the care have been put in place, and if we use the skills of our whole team at the utmost scope of their scope of practice. And as a team, do we really need to be expecting the situation might improve? If we put in IV fluids and the bisphosphonate and the antibiotics to treat hypercalcemia and infection, then maybe it's actually watchful waiting. And I sometimes think watchful waiting is not something that we do well. We respond very rapidly to distress. And I think in delirium care, watchful waiting with support around the person and their family is a very reasonable and positive option to think about. And informed shared decision-making, particularly when you're thinking about proxy decision-making around off-label use of the medicine is really important. And that delirium, it's in the medical emergency chapters of most palliative medicine textbooks. So it's really a senior level clinician responsibility, and it's often left to quite junior staff in terms of the medication prescribing and some of the explanations that families are receiving. And reassessing regularly in terms of that assessment aspect is really important. So then thinking about the loss and grief aspects, delirium and cognitive loss is an ambiguous loss, and behaviours are incongruent with the person that the loved ones have known. And so we really need to realise that the person we're seeing is not the person that the family know and love, and this disenfranchised grief is a really important aspect, and we need to be really trying to explore an understanding of who that person is in the eyes of the family and the things that have been lost that we may be quite unaware of as the person is in front of us. So we've done some work to see whether perspectives are shifting, and this is Australian data, and there's been work by Jason Boland in terms of the UK perspective. But we are starting to see increase in non-pharmacological interventions being reported, people describing in much more communication with patients and families, and decreased pharmacological interventions, and particularly in our survey that covered a range of specialty groups. This practice change was higher in the palliative care respondents than some of the other disciplines. And when we think about the areas that are influencing delirium treatment, what comes out strongly is this emotional aspect, that the distress of the person, the family, and other care recipients, and unsafe behaviours, and particularly if this is in the terminal phase, really become quite high up in what is driving people's decisions and choices in terms of care. So I think the opportunities are that if we're starting to put mental awareness as something valued and put it front and centre, that will really, I think, be an important mind shift in trying to apply the full interdisciplinary care that we do have on offer for these patients. That listening to the story, and that's the full story, the meaning, the context, the changes over time, not making assumptions about preferences and values and treatment priorities, and making true shared informed decisions wherever possible, involving the person themselves, and really improving the way we communicate as a whole team and hearing the whole story as a whole team. I think are really important things that we can do, and that will fundamentally improve care for people with delirium. In terms of treatment, I think as the WHO definition tells us very wisely, that early detection and assessment is so critical in every aspect of symptom control and distress that people may experience at the end of their life, whether that's a physical symptom or other areas of need. And that for many things we can actually put in some preventative strategies that might prevent these things happening in the first place. Really allow the non-pharmacological approaches to weigh in and understand the scope of practice that our interdisciplinary colleagues have to offer, and provide those opportunities to make those really central to the holistic care of people with delirium. And really have senior clinicians really engage and lead and model this type of care, and particularly how they position pharmacological therapies in interdisciplinary care. And I'll just leave you with this quote from our colleagues from ICU at Vanderbilt, who reflect that when we're thinking about hyperactive delirium in the last days of life, that it's about the humanness of medicine, and that yes, we do want to keep dying patients as comfortable as possible, but also to really think about how awake they would like to be, so those last few hours of day and days of life can be meaningful, and not cloud sensorium unless it's really essential to alleviate severe pain or other severe symptoms. So I'll stop there and very happy to take any questions.